Welcome, and thank you for taking time to view this webinar. I am Kris Sundberg, the Executive Director of Elder Voice Advocates and Elder Care IQ, which is our new quality care screening tool for nursing homes, assisted living, home health care, hospice, hospitals, and other healthcare providers. It is a pleasure to have Eilon Caspi here to talk about one of the cruelest forms of elder abuse, and that is theft of opioid pain medications. Eilon is a PhD in gerontology and a dementia behavior specialist. He currently works as an assistant research professor at the University of Connecticut. In recent years, he has conducted several studies to improve understanding and the prevention of various forms of elder mistreatment in long-term care, such as injurious and deadly neglect of health care, fatal resident-to-resident incidents, financial exploitation, and theft of opioid medications. He serves on the board of Elder Voice Advocates and the Long-Term Care Community Coalition in New York City. In his free time, he enjoys carving wood, and you can see a beautiful example of his work over my shoulder. Thank you and welcome, Eilon.
Well, thank you, Kris, for the introduction. Today, I'm going to talk about one form of elder mistreatment that I believe does not receive enough attention in practice and research and in policy. That is the theft of controlled substances in long-term care homes. Today, I'm going to focus on a study that I led using data from Minnesota, and it is an exploratory study. So I want to recognize my research collaborators, Assistant Professor Piju Liu, and her doctoral student, Wei-Ling Xie. Both are from Purdue University School of Nursing. They are fabulous, fabulous research collaborators. So I want to thank them for all their help with this project. I want to recognize Elder Voice Advocates for the inspiration for this project, and also Stevens Square Foundation for funding an early part of this study. Lindsay Kruger and Minnesota Department of Health Office of Health Facility Complaints Investigators, without whom this study could not have been conducted. And I want to thank Carrie for giving me permission to use her mother's photo in a couple of slides. We'll see it. I also want to recognize Chris Sears, who recently did a story about these thefts of controlled substances from long-term care homes in Minnesota based on our study. I want to dedicate this presentation to Lavon and the late Roger Borsheim. Their story is described in a recent New York Times article. And I'm just going to share a little bit about what happened to Lavon. She lived at home near Minneapolis with her husband, and she had severe pain, and a nurse came into their home, and he was supposed to administer the pain medications. Instead, he stole the medications and left her in an excruciating pain for an extended period of time. This was reported by Car 11, and the nurse eventually was caught and was sentenced to 18 months in federal prison. I should mention that prior to stepping into Lavon and Roger's home, this nurse was accused by 8 clients in 2 prior home health agencies for stealing narcotic medications. And Lavon herself said, "I didn't understand why I was still having so much pain all the time." Her husband said she asked God to take her home to heaven because she could not go on. And when asked, "How did you feel?" Miss Borsheim said, "Very violated. We felt that he was our friend and he broke our trust." These phenomena of theft of opioid pain medications from residents in long-term care homes does not occur in a vacuum. It is important to recognize that it is influenced directly by the opioid epidemic in this country and the sharp growth in overdose deaths in recent years that is driven largely by OPM, which stands for opioid pain medications. In fact, the CDC reported recently that during the year 2021, there were over 100,000 overdose deaths in this country. I also want to point out that there's a relationship between the misuse of controlled substances and their theft. And another issue that this phenomena of these thefts is embedded within is the long-standing concerns about medication management and safety in assisted living and nursing homes. In fact, in 2010, this was the title of a journal article, "We've Got Trouble, Medications in Assisted Living." In fact, in 2003, the National Assisted Living Work Group report to Congress, which consisted of hundreds of pages, the largest part of this report addressed medication management and safety in assisted living residences, so nothing new. The Controlled Substances Act classifies these medications from Schedule 1 to Schedule 5, depending on the drug's medical usefulness, abuse potential, safety, and drug dependence profile. Schedule 2 has high potential for abuse, and it may lead to severe psychological and physical dependence. Now, I should mention that as the schedule level increases, the potential for abuse and dependence decreases. For example, Schedule 1 of controlled substances are drugs that do not have an authorized medical use in the United States. For example, heroin. Now, the most common term used in the practice and research is diversion, which is defined as the transfer of controlled substances from a lawful to an unlawful channel of distribution or use. However, I strongly recommend avoiding using the term diversion in most situations. And it has to do with the fact that this is an institution-centered term, not a resident-centered term. These medications, at least in our study, belong to the residents. This is their property. And the term diversion disregards, devalues, and dismisses the experience of victims of these thefts. We need to simply call it what it is, theft. And Kris Sandberg recently commented on this phenomena. She said, "We need to stop sanitizing this cruelty by calling it drug diversion. We need to call it what it is, criminal theft of pain medication." So my research team conducted a thorough review of the research literature, and led by Eilon, who is the doctoral student I had mentioned earlier. And she found that research studies were conducted on these thefts of controlled substances, were conducted in hospitals, pharmacies, hospice settings, and pain clinics. However, we were not able to identify a single published study on the theft of controlled substances in long-term care homes published in English to date. After immersing ourselves in this phenomena for a year and a half now, we strongly believe that these thefts should be considered as a largely invisible form of elder mistreatment in long-term care homes. In fact, experts tell us, let's face it, diversion of controlled substances is more common than we think, but it is usually kept quiet in long-term care facilities. We also know that drug thefts are not tracked nationally in CMS State Survey Deficiency Citation System, which is also called the FTAG system, in approximately 15,000 nursing homes. It is also not being tracked in NORS, which is the National Ombudsman Reporting System, which tracks mistreatment complaints in assisted living and nursing homes. Left untracked, in effect, this phenomena doesn't exist, and CMS and other agencies are not in a position to address it. We also know that long-term care homes struggle to address these thefts. In fact, Patty Cullen, president of Care Providers Minnesota, said recently, every year there is a new and creative way for someone to steal drugs. It's almost like chasing a turning wheel. And one employee who was found to steal PRN as needed controlled substance medications from the supplies said that the theft was so easy. It was so easy to steal the medications. I should mention that Minnesota does have an educational program designed specifically to prevent these thefts. It's called the Minnesota Drug Diversion Prevention Pathway, which was published in 2019 based on a multi-stakeholder effort and experts input. The systems that this educational program are meant to assist care homes are to decrease opportunities for these thefts, to quickly identify when someone is stealing. And one of the concepts used in this education program is called the chain of custody, which basically means that we need to know who had access to and responsibility for controlled substances at all times. And every dose is accounted for when access and responsibility changes. And there's a link to the report at the bottom of the slide. There are potential consequences for multiple entities. Of course, residents who are victims of these thefts, family members, employees stealing, coworkers, the care home, and the general public. Examples of potential consequences for resident victims: increased pain, which is avoidable, allergic reaction to replaced medication, infections such as hepatitis C virus, such as due to compromised syringes. Residents may experience substandard care or even gross neglect from staff members who are chemically impaired, and their privacy may be compromised when their clinical records are inappropriately accessed in an attempt to steal their medications. Potential consequences of family members. When learning that a relative didn't receive their pain medication or receive medications not prescribed, family members may experience frustration, anxiety, and anger. They may experience guilt for placing the loved one in an unsafe care home, and their trust in the long-term care sector may decrease. Employees stealing those medications may experience stigma, such as being called drug addicts. They may experience loss of employment, loss of licensure. They may be subject to criminal prosecution or civil malpractice lawsuits. They may serve jail time. They may themselves may be at risk of infection, such as when using unsterilized medication. Those thefts can also help develop or exacerbate their substance use disorder. And they may suffer a chemical impairment. They may also experience accidental or deadly overdose of those controlled substances. And there are costs associated with emergency department treatment and rehabilitation. Coworkers may experience anger, guilt, feeling of betrayal due to the theft by a trusted colleague. They may themselves may be at risk of disciplinary action and liability due to sharing responsibilities with an employee stealing medications. And they may be, a nurse manager may be charged with negligent supervision when she or he failed to report an employee suspected or found to steal controlled substance medications. With regards to potential implications on the care home as a whole, the theft of those medications could bring about loss of staff time that could otherwise be used for provision of personal care. And that has to do with the need to search, investigate, and report these thefts. Employees who are chemically impaired may not show up to work or leave in the middle of a shift, which could impact the care home ability to provide adequate care to residents. There is substantial cost of replacing employees found to steal medications. The care home may be subject to regulatory deficiencies or fines for lack of adequate safeguards. There may be costly litigation or charges for fraudulent billing, such as for prescribed medications that are ordered by the physician, but are not given to residents as needed. And there may be adverse media publicity for the care home. In terms of the impact on the general public, employees that misuse the stolen controlled substance medications may place others at risk, such as when the medications are sold to people who misuse them and therefore contribute to worsening the opioid crisis in the local community. And there could be other implications, such as reckless driving after ingesting controlled substance medications while working at the care home. In fact, a 37-year-old employee from another state stole propofol from a medical center. She was allegedly injecting 2 vials of the drug, and then she drove 3 miles in the wrong direction on a highway and caused a serious injury and crash. Here in Connecticut, 20 minutes from where I live, in East Haven, a nurse paid a visit to the assisted living home only to find 2 and only employees completely overdosed, where controlled substances were spread all over the place, leaving residents unsupervised. And more recently in North Carolina, employees were found with residents' medications while sleeping at work. So here you can see the potential impact on neglect, direct neglect of residents' care. Here I'm going to give a brief overview of our study. In our study, we used 107 MDH investigation reports that were substantiated by the agency as diversion, as the agency calls these acts. The care settings included 104 unique care homes consisting of 74 assisted livings and 33 nursing homes. The time period within which the investigations were concluded were between 2013 and 2021. MDH started using a unique maltreatment code classified as drug diversion in fiscal year 2014 for their internal tracking. Prior to it, it was classified using a broad code termed as financial exploitation. The new internal tracking created the opportunity for us to conduct a study and access the data using my data practices request to the agency. I won't get too much into the analysis process, but we conducted a qualitative review and abstraction of the narratives, those summaries, those text-based summaries that surveyors write up in their investigation reports. This was complemented by tabulation with aggregation of attributes or pertinent data elements. We also developed a structured guide that we then use systematically and consistently to detect and extract excerpts from those investigation reports to those what we thought were important data elements. Overall, over 11,328 tablets were stolen. In fact, we know that the number was substantially higher because in 12% of the investigation reports, MDH did not specify the number of tablets stolen. We also used a conservative approach whereby if a range of number of medications stolen was noted, we calculated only the lowest figure in the range because we wanted to be credible and we didn't want to inflate the numbers that we report on. Overall, there were 368 victims of these thefts. And on average, over 30 medications were stolen per resident. That being said, the medication thefts identified as stolen in our study were substantiated in only a small subgroup of these care settings in the state. And the reason has to do with the fact that at the midpoint of the data set, around March 2017, there were over 1,200 assisted livings registered and over 370 licensed nursing homes in the state. And so we have to be fair and say it as it is. That being said, experts tell us that the problem of controlled substance thefts in healthcare settings is substantially underestimated, it is underdetected, and it is underreported in those care settings. We have no reason to believe why it would be any different in long-term care homes. In terms of the types of medications stolen, nearly all the medications, 97.5%, were controlled substances. 94% were opioid pain medications. Schedule 2, which as you recall is the most dangerous schedule level of controlled substances, was the most common. 77% of the controlled substances identified as stolen were at this schedule level. And the most common types of stolen medications, of controlled substance stolen medications, were oxycodone, hydrocodone, tramadol, hydromorphone, and morphine. In terms of a comparison between assisted living and nursing homes, 85% of the medications stolen, that is over 9,609 medications, were stolen from 208 residents in 71 assisted living residences. The remainder 15% were stolen from 160 residents in 33 nursing homes. In Lindsay Kruger's words, assisted living residences need to have strong safeguards in place to protect older adults' medications. That being said, a word of caution. In the midpoint time point of our data set, there were nearly twice as many beds of assisted livings compared to nursing homes. Therefore, we need to avoid making unbalanced statements regarding the scope of medication theft in assisted living when compared to nursing homes. Research is needed to determine whether, and if so, to what extent, assisted living residences are at greater risk of controlled substance theft. In terms of the duration of theft, on average, the length of theft was basically 2 months period, which is a very long period when you think about 2 months period of employee capable of stealing medications without being caught. And you see the comparison between assisted living and nursing home in terms of duration of theft, with the caveat that I mentioned earlier. We were also curious to know what was the type of employee stealing. And in half of the cases that were confirmed as thefts, the employees who were stealing the medications were nurses. The vast majority of the rest of the employees found to be stealing the medications were direct care staff members. Now, it is important to recognize that chemical dependency among nurses has long been recognized as a serious public health problem. In fact, it is recognized as one of the most serious problems facing the nursing profession today. And in those 65 investigation reports that had relevant information to determine it, employees stole, in all those 65 investigation reports, the medications were stolen for personal use. That being said, there must have been some exceptions. For example, in one case, an RN created a storage space in her own office and managed to steal 1,900 controlled substance medications. And it would be hard to imagine that this nurse was able to consume all those medications by herself. And therefore, it is possible that the nurse sold those medications or some of them, but there is no way for me to know that. In only 23 investigation reports, some indication of the reason for the theft was stated by the employees stealing them. 8 employees reported stealing the medications to treat their own pain, back pain, tooth pain, or skin rash. 1 employee took the medications because she was on them and was running low. 3 employees took the medications for family and friends for their pain treatment. And 1 employee attributed the theft to a stressful life event, specifically a recent death in the family. Addiction to painkiller played a significant role in those thefts. 1 employee was struggling with addiction and had reported to have had a weak moment when she or he stole the medications. Several employees were chemically impaired while working their care shift. In one case, one disturbing case, I should say, on several consecutive days, staff told managers that an RN, a registered nurse, seemed off. She was pale and sweaty. She swayed back and forth, fell asleep while standing up, and about to pass out. The registered nurse was found to steal a combined total of 100 tablets of hydrocodone and oxycodone over a several-month period. Now, I would be remiss if I wouldn't mention RNs are responsible and delegate critical care tasks to LPNs and direct care staff members. And if an RN is chemically impaired, this could have devastating effects on the ability of the rest of the care team to provide adequate care. Now, some employees provided statements about those about the reasons why the medications were missing or could not be found. One employee said it must have been fallen out. Another employee who signed out medications and documented the resident simply ran over the medications with a scooter, and the tablets were destroyed. Police officers asked why an employee took the medications, and the employee said it was a rush of some sort. Another employee said she made a poor decision when she took the resident's medication. Employees who were stealing the medication hid them in different places, whether it's in a pocket, a waistband of pants. One employee put it in the drawer, then came back later and put it in a sock. One employee put it in her bra. Fentanyl patch was found on an employee's skin. In one case, an employee put it in a purse and then flushed it down the toilet, possibly when she or he panicked when learning that police were involved in the investigation. An employee put a controlled substance medication stolen in a bag or a handbag. Medications were found in an envelope on the floor, in a trash can, in an employee's vehicle, in an employee's home, and others put the medication in their mouth and ingested them. In fact, this slide shows several cases where employees ingested controlled substance medications while working their shift. Only 6 investigations, including detailed description of the harm experienced by residents due to these thefts. 4 consisted of increased pain, and in another case, an employee replaced and gave blood pressure reducing medication to a resident with low blood pressure. And according to staff and police, this could have resulted in a serious injury or death of the resident. One resident became very upset over the missing medications. Future research needs to examine harmful effects of controlled substance theft in long-term care homes, including emotional effects, physical effects, healthcare costs, and I should add also the nursing time required to search, investigate, and report internally and externally those thefts. Precious time that should be used for personal care to residents. 80% of the employees found to be stealing the medication admitted to the theft. This consisted of 64% who admitted to the theft and 16% who eventually admitted or partially admitted the theft. Nurses played a key role in initially suspecting the theft in 43% of the investigations, possibly higher. In another 42%, staff, unfortunately unspecified what type of staff, initially suspected the theft. In other cases, it was resident, family, and others, such as trained medication assistants, that initially suspected the theft. Here I'll give a few examples of suspicion, how the suspicion arose of those thefts. In one case, a nurse noticed that the oxycodone syringes appeared lighter in color than new syringes she just set up. Speaks to the vigilance of that nurse. She noticed bubbles in the solution, and the measurements were not as exact as usual practice. When she fills syringes, there are never any bubbles in the solution, and they are precise measurements. In this case, staff noticed that the cover of the medication cassette did not pop off like it normally should. The cover had already been removed and then put back on. The medications in the cassette weren't oxycodone, but they were Claritin and ibuprofen. The medications that were replaced and put in looked similar in color, shape, and size, possibly to conceal the theft. In another case, staff heard rustling sound of a bubble pack from a public bathroom. A search discovered the bubble packs missing from residents' locked medication storage box. And a search in the bathroom discovered 1 tablet on the floor and 2 bubble packs missing 39 pills wrapped in a paper towel in the trash can. In this case, a nurse tried to refill physician order for a resident, and the pharmacist said it was too soon to refill it. The nurse went on to check the medication administration records and the physician order and found that the resident should have had 30 tablets remaining. The nurse noticed that an employee had logged in narcotic medications, when the nurse always logs medications in after receiving them from the pharmacy. In this case, a document review and staff interviews found that the residents rarely requested tramadol. Yet staff placed orders for refills over a 2-year period. A total of over 1,800 half tablets were missing. In this case, an RN noticed that an employee signed out tablets for residents before they were scheduled to be administered. The nurse discovered a pattern whereby the employee often signed out controlled substances outside prescription instructions. Staff saw an employee with an expired medication and offered to destroy it, but the employee was very reluctant to relinquish it. The employee also insisted on putting the medications away later by herself. She also tried to talk residents into taking narcotics. In this case, managers and staff suspected because an employee had a pattern of more PRN, that is, as needed medications, signed out than other staff members. There was a lack of consistent reason as to why an employee had a pattern of failing to document in the electronic medication administration record. And that employee was the only one with a positive drug test for opioids. In this case, no residents had any scheduled medications over the night shift. None requested medications that night. The employee had no reason to be in the medication card, and the employee was the only person with access to the medication card during the shift. 18 morphine tablets were accounted for at the shift start. They were gone at the end of the shift. In this case, staff found that Tylenol tablets were in the medication setup box that should have been oxycodone. During a routine count of narcotic medications, 2 tablets did not match other tablets in the bottle. There were also inconsistencies in narcotic counts that were identified. And in another case, the pharmacist alerted that tramadol controlled substance medications were replaced with caffeine tablets. Nurse found that all the cassettes with tramadol appeared tampered with. An expanded search found other medications tampered with. Police found medication caps in employees' pockets. In this case, employee was seen on a video surveillance camera in the medication cart, more than required during her or his shift. The employee frequently talked about his or her inability to get prednisone because of lack of health insurance and not being able to afford it. The employee displayed symptoms of prednisone overdose, and he or she were seen agitated and sweaty lately and manifesting other changes in behavior. Here, I would like to talk a little bit about the role of surveillance camera. In 1/4 of the investigation reports examined in our study, camera footage provided evidence of the theft. And you can see here on the slide the breakdown of the location of the camera that provided the evidence, whether it was in a medication room or medication cart, in the victim's bedroom, in a public space, such as the hallway. And I should add that 4 employees who initially denied stealing the controlled substance medication later admitted when informed about camera footage. We're going to talk about the role of surveillance camera later on, the importance to increase the use of it in care homes. And a nurse who was not part of this study wrote me, "I am very pro video monitoring. It is much safer for me. The presence of video cameras throughout the assisted living and in residence rooms is making gathering evidence easier. It should help cut back on thefts." That said, I should add, it is important to strike a good balance with protections of privacy of residents in their own bedrooms and bathrooms. Here, I would like to give a few examples of camera footage that were identified in the investigation reports in our study. In this secure dementia care unit in the nursing home, employee found to steal medication from 9 residents with dementia. On 15 occasions, the video surveillance footage provided evidence of the theft. In 4 of these occasions, the video showed the employee putting the pills in her mouth under her mask. On 3 occasions, the employee put the pills into her pocket, and in 8 occasions, the employee was seen on video taking the medications, putting them in her hand, and walking out with a clenched hand outside the bedroom. And given that this investigation report was concluded in October 2020, it is possible that this theft occurred during COVID-19 pandemic. In this assisted living residence, a longtime employee who was a lead caregiver in charge of medication ordering and checking in medication deliveries stole 7 Percocet medications from a resident. At least one of those were ingested by the employee. The employee denied the theft, but after being confronted with the video surveillance evidence, admitted to stealing the Percocet. In this assisted living, an unlicensed staff stole multiple oxycodone medications from a resident with Alzheimer's disease who was receiving hospice services, speaking about the vulnerability of this population, their exploitation. In concert with the family, the administrator placed a video recorder in the bedroom. On multiple occasions, the video showed that the employee placing oxycodone tablets in her mouth or placing them in a cabinet and later picking them up. Interestingly, this employee, who was an unlicensed staff at this point of this report, used to work as a registered nurse, but had a suspended nurse license for drug diversion. In the next couple of cases, there were allegations of other types of mistreatment that led to the discovery of the controlled substance theft. In this secure dementia unit of an assisted living residence, unlicensed staff stole medication from a resident with dementia and lymphoma. The client alleged sexual assault by an employee, camera footage reviewed. This was when the medication theft was discovered. Footage in the hallway showed that an employee removed medication from residents' medication supply and medication cart and ingested them afterwards. Now, again, if this allegation of sexual assault would not come forward, it is possible that we would have never learned about this controlled substances drug theft. Similarly, money kept disappearing from the administrative office in another assisted living. So they placed a camera. The video showed an employee stealing $400 that was a rent payment. The director of nursing became suspicious and checked the narcotic counts. Out of due diligence, one resident was missing 120 hydrocodone medications. The same employee was the only one with permitted access and keys to the overflow medications. It was discovered that the employee stole 140 tablets from the overflow storage, medications belonging to 2 residents, one of whom with cognitive impairment. In this assisted living, resident reports that medication bottle was missing 90 pills. So the administrator placed a hidden camera in the bedroom. And lo and behold, theft observed on the camera. The employee admitted to the sheriff deputy she borrowed medications from the resident's cabinet a few times because she had been on it herself and was running low. In this assisted living, residents report 180 pills were taken from his or her medication drawer. 3 days later, additional 12 pills are taken. Family placed OxyContin tabs in 2 plastic bags, placed one of them in the bedroom and another in the medication drawer, and installed the camera. An employee was seen on camera entering the bedroom without permission and without an assigned task. Camera footage took photos of the employee in the medication drawer. The baggie and the pills in the medication drawer were gone. Excuse me. In this assisted living, resident expressed concern regarding missing medications. Camera was placed in the bedroom. 2 days later, the administrator reviewed the footage and observed an employee opening medication bottles, taking and placing pills in the pocket. Police found residents' pills in the employee's pocket. And in one case, it was a 2-person's job. A registered nurse stole 560 tablets from 5 residents on 5 different occasions. These medications were surplus supplies awaiting placement into the central storage area. In one occasion, the video footage showed the registered nurse legging another unknown person into the office. That person broke into the locked cabinet and toolbox containing the controlled substances medications. I would like to talk a little bit about the techniques of theft, to give some examples, and also highlight how they vary in level of sophistication and creativity. This case is not really a technique, it's pretty straightforward. An employee entering the bedroom and pouring medications out of the bottle and taking them. In this case, an employee enters the bedroom and placing a pillow on top of the pill bottles while pouring the pills into her or his hand. In another care home, an employee replaced controlled substance medications with other medications that were similar in appearance or shaven down. In another case, an employee slit the foil backing of a medication card with sharp object and then resealed it with glue. In another case, an employee took the medications and diluted the solution in the syringes. In another care home, an employee addicted to painkillers enters the medication room, attempts to unlock the file cabinet, but unsuccessful in doing so. The employee steps out of the camera view and returns within seconds, puts an object into the lock and opens the doors. In this case, an employee enters the bedroom, opens the locked medication cupboard, and pries the medication box open with hands, which tells us that locked medications, boxes, or cupboards are not necessarily secure. The employee was able to remove 30 pills and place them in a drawer. The employee exits the bedrooms and comes back later, takes the pills from the drawer, places them in their sock, and walks out. So a two-step theft process. Some employees used falsification of record as part of the theft process and possibly in an attempt to conceal the theft. In many cases, I should say, employees signed off pills as if given to residents when they were not. In other cases, employees signed out extra tablets without documenting the reason. In other cases, employees signed out PRN as needed medications as if residents requested them when they didn't. In other cases, employees falsified inventory counts of controlled substances and their dates. In other cases, employees forged nurses' signature on medication destruction records. And in other cases, employees tore the count sheet out of the tracking book. In this case, a nurse was notified that tramadol card was missing. She notices her signature was forged in the narcotic med book, where 2 signatures were required for the destructions of meds. Each time her signature was not authentic, the second signature was of the employee stealing the medications. In this case, an employee told another she's getting good at forging nurses' signature on the medication destruction records. The employee discontinued medications alone without a nurse against policy. Staff reported to nurse who conducted an investigation, and the employee admitted to police that she or he stole the medications for personal use. Here I'm going to give a few examples of how the thefts were caught. In this case, it was the family who suspected the staff are stealing medications. When residents were outside of the bedroom at dinner, housing director sat quietly in the apartment, observing and witnessing an employee coming in, pouring medication from a bottle, and leaving. In this case, the care home discovered fentanyl patch missing from a resident. They contacted police and identified a particular employee as a suspect. Police went to the employee's home and noticed she was wearing a fentanyl patch on her arm. In this case, when the care home discovered that the medications are missing, a random drug test of employees was initiated. The employee admitted to having an addiction to oxycodone and that she would fail the drug test. As many of us know, when an MDH surveyor completes an investigation of maltreatment, they make a determination as to who was responsible for the maltreatment. In nearly 3/4 of the investigation reports in our study, MDH surveyors determined there was an employee responsible for the maltreatment of those thefts. In an additional 21%, it was an employee in a long-term care home. And it was only in 6% that it was determined as the sole responsibility of the long-term home. And I would like to question that 6% a little bit. In a previous study that I led, over 3/4 of 300 MDH investigation reports substantiated as resident neglect that resulted in a serious bodily injury or death of the resident in long-term care homes. MDH determined that it was the sole responsibility of the long-term care home. In an additional 8%, it was both the long-term care home and the employee. Granted, these are different types of mistreatment, but still, I really believe that we need to look more closely into this 6%, and also to consider reframing these thefts of controlled substances as a subtype, as a unique subtype of resident neglect. That is, when care homes neglect to protect controlled substances, pain medications needed, belonging to and needed by residents. So we decided to look in more depth into this issue. Well, we had a data element that we classified as opportunity for theft. What are those weak links? What are those lack of safeguards in place that were identified in our study? And 4 main patterns came up in our rigorous separate qualitative analysis that our team conducted. The first pattern was policy and procedure not followed, or doesn't exist, or inadequately followed. That was a pattern, but it also we also considered it an overarching theme because in many cases it cuts across pattern number 2, 3, and 4. Pattern number 2 was medications were left unsecure. Pattern number 3, red flags missed, and pattern number 4 we classified as other areas of vulnerability awaiting exploitation. And I would like to give a few examples of the overarching theme / pattern. In many cases, controlled substances were not reconciled against policy. They were not counted at shift change. There was no second witness at controlled substance medication destruction against policy. There was a lack of narcotic medication audit process. Staff suspecting controlled substance theft in some cases did not report it. In one case, an employee says that she or he didn't report it because she or he likes to stay under the radar. In another disturbing case, on an ongoing basis, employees suspected a particular employee stealing controlled substances, but they did not report it to management because they claimed that this employee was a friend of leadership, and they didn't see a point of reporting it because they believed that leadership will protect that employee. So yes, failure to report controlled substances theft suspicion to Minnesota Department of Health. And there were cases whereby background check was not done upon employee hire, employee that later found stealing controlled substances from residents. This is a quote of a director of nursing. For a long time, we did not do narcotic counts as we trusted one another. It is a small facility and everyone knew each other and we trusted nothing would happen. It does not take long to count the medications. It was laziness on our part. Moving on to pattern number 2, medications left unsecure. Where there was inappropriate access to medication room, a medication cart unlocked or left unattended, medications left on a desk, laying on a desk at the nurse stations for hours, box that is locked, but insecure because you could slip your hand and grab the medications. And in other cases, keys, many cases I should say, keys were left unsecure, whether hanging on the wall, laying on a desk, in an unlocked drawer, or in a nurse's bag. And many employees can come and go and just grab those keys and access controlled substance medications. The third pattern we describe as going out of the way to assist in quotation mark, coworkers, whether it's offering to care for an unassigned resident and then targeting them with those thefts, or responding to a call out on another unit, or volunteering to feed a resident's fish when the resident is away in order to steal medications. One employee always wanted to destroy controlled substances medications, but never non-controlled substances. In other cases, the care home missed numerous forging of signatures of co-signing nurse for destruction, which is required under policy. In other cases, employees stealing medications had no reasons to be in that particular area, whether it's in the resident's bedroom or a different care unit, completely different part of the care home. And in other cases, there was lack of employee monitoring despite history of drug theft. The fourth and last pattern we describe as other areas of vulnerability awaiting exploitation. excuse me. In several cases, those thefts occurred on a night shift, which some care staff described as a vulnerability area for those thefts. And in other cases, they were stolen during delivery from pharmacy, where they're left on the desk for a nurse for several hours until she is available to secure them, and or delivering controlled substance medications in unsecured medication delivery packages. That's really could be an easy solution there with affordable medication delivery packages that are used in other care settings. In other cases, medications were stolen from discontinued medication drawer before the RN destroyed them. In other cases, medications were stolen from a surplus medications awaiting placement in the central storage medication cart. In another case, an employee exploited the fact that they shifted to a new medication cart system. And in another case, an employee stole medications when a resident was away. In several cases, I should say, an employee took advantage of residents being away from the bedroom, whether it's in a group activity or a dinner, or when the resident was in the hospital, on vacation, transferred, or discharged. And then we saw that employees targeted residents that either received larger doses of controlled substances or those living with dementia. And here is management and non-management staff in assisted living said, a diversion of this magnitude could only be done during the overnight shift due to the time needed to remove and replace the tablets. We also found that in only 5% of the investigation reports in our study, 107 investigations, MDH, CC, DEA, and granted, not all substantiated diversion reports should be CC'd to DEA, but still, there's a big question mark as to what makes it so that such a small fraction of substantiated thefts of controlled substances are reported to DEA, to the U.S. Drug Enforcement Agency, that one of the main goals of the Drug Enforcement Agency is to use what they call the closed system. And I'm concerned that the long-term care homes, assisted living and nursing homes are a weak segment of that closed system. There's reasons for that, but that's beyond the scope of our presentation today. I want to start the process of concluding this presentation by saying that the large number and dangerous type of controlled substances medication stolen. Remember, 77% of the controlled substances stolen were at the dangerous controlled substance Schedule 2. In combination with the lengthy duration of thefts, oftentimes, I believe warrants a coordinated multi-stakeholder strategy and proactive intervention. And you can see on the slide the different entities that should be integral part of this initiative, whether it's long-term care homes in close collaboration with residents and families, long-term care trade associations, state survey agencies, ombudsmen for long-term care, law enforcement, Medicaid fraud control units, boards of nursing, pharmacy, and medicine, the American Nurse Association, DEA, researchers, and care advocacy organizations. The key component of any intervention is employee education. And here we mean not just the care staff and nurses, but every employee who comes in direct regular contact with residents, that is housekeeping staff, dietary, front desk, maintenance, every employee who comes in direct regular contact with residents. And all of them should be educated in residents' rights in the context of these controlled substances, policies, procedures, contributing factors for those thefts, safeguards, methods of thefts, signs and symptoms of chemical dependence, and staff behaviors that should raise suspicion of theft. In an extreme case in our study, a registered nurse said that she was not aware that the suspected missing medications were considered the property of the vulnerable adult and part of the definition of financial exploitation under state law. And not surprisingly, the RN did not report the incident of suspected drug theft to the state. Now, if an RN doesn't know that those controlled substances belong to residents, that's their property, then it is possible that some licensed practical nurse under the supervision of the RN and many direct care staff members, unlicensed staff often, or nurse aides don't know that either. This is basic knowledge. So as experts tell us that employees must be educated and be vigilant to signs of those thefts, such as signs of addiction, and they often could be subtle, such as suspicious situations, underperformance by an employee, behavioral changes such as diminished alertness, frequent unexplained disappearances or work absences, and frequent ineffective pain management despite treatment documentation. I think an important concept to consider is called the deterrent environment, which is defined as the perceived certainty of detection and perceived severity of punishment among those who are in a position to commit offenses within the organization. And previous research in nursing homes found that the deterrent environment is weak in nursing homes. I do not have a reason to believe that the deterrent environment in many of those settings in our study do not have, let me put it this way, I believe that many of the settings as we've seen have a weak deterrent environment in the context of security of controlled substances. Our study that showed that only a quarter of those thefts were caught on camera warrants the need to increase smart use of surveillance cameras in strategic locations. However, we must make sure that it's balanced with protection of residents' privacy. The Mayo Clinic many years ago discovered that they have a big problem with the theft of controlled substances in some of their healthcare systems. They developed a comprehensive multi-stakeholder best practice intervention. And since the initiation of these improved control systems, they report on a dramatic decrease in the frequency of controlled substance diversions, those thefts. And you can see here, and at the end of this presentation slides, a link to this detailed report. And I want to go over some of the components of this intervention. They also, by the way, highlighted the importance of close collaboration between all key stakeholders. They talk about the need to raise awareness to these thefts and educate all employees about the risk and potential harms. The importance that all workers must be vigilant for signs of possible theft and addiction. Criminal background checks are very important, and they must be done adequately. And providers must check and verify the candidate employee status and current employee status in nurse assistant registry, as well as in the Board of Nursing nurse registry for nurses. There must be a need to strengthen methods for detection and surveillance. There need to be a system to deter thefts and to be very clear about the consequences for employees stealing, as we discussed earlier. There need to be a thorough and immediate investigation of any medication discrepancy and suspected thefts. And there needs to be a documentation of the investigations in detail while ensuring appropriate confidentiality. Other components of the intervention at Mayo Clinic, policy and procedures must be in place for quick intervention when suspicion arises, including training employees in securing evidence once a suspicion arises. There must be prompt reporting of suspected thefts to police and state survey agency, and corrective actions must be implemented to prevent theft. And the Mayo Clinic was so concerned about those thefts that they created a new position that is called Drug Theft Prevention Coordinator that works as part of the theft response team at the Mayo healthcare system. They also develop mechanisms for shared learning from each theft, and I should add each suspected theft and every unaccounted missing controlled substance medications. Now, shifting gears a little bit, we have to recognize that the theft of controlled substances is often a symptom of the disease of addiction, and that addiction is a treatable disease in many cases. And experts from Mayo tell us that typically drugs stolen from care facilities are used to support addiction, and that less commonly, they are stolen for sale and financial gain. And I really want to highlight that these individuals who steal controlled substances in long-term care home need help. They need support, they need treatment, and they need rehabilitation. They are whole human beings with families, and these thefts could cause chaos, complete chaos in their families and their ability to provide the families. And therefore, we must ensure that a delicate balance needs to be struck to increase the likelihood that a safe and dignified outcomes would be realized for all parties involved. Many of you may have heard about the film Dope Sick, which came out in 2021, and you can access on Hulu. And in this film, which was well done, it's 8 episodes. I watched it recently. It really brings home the message whereby people who had a car accident or a sport-related injury received pain medication, controlled substances, and they became addicted. And then they started stealing those medications, including the physician who initially prescribed those medications for them for their pain, who became addicted himself. You can see Michael Keaton here on the cover of the film, and what happened to him as described so compellingly and sadly in the film. So we need a compassionate intervention. So on one hand, this is a crime. There is no question that stealing controlled substances is a crime, and employees need to be held accountable. On the other hand, they need support, and support needs to be non-judgmental. It needs to be done in a stigma-free way, and it needs to be done in a compassionate way. Providers, in some cases, need to consider what is called alternative to discipline programs that are offered by many boards of nursing across the country. In Minnesota, it's called the Alternative Monitoring Program. But I must add that if employees are referred to these programs, they must be monitored for the person's recovery. They must be carefully monitored for their safe recovery. If at all, they're considered for return for safe practice. And even if they're returning for safe practice, there got to be some restrictions on their ability to access controlled substances, or, for example, restrictions on their ability to access controlled substances or work on night shifts, I should say. So it's a delicate balance. And if you're someone you know needs help, you can call the Minnesota Health Professions Service Program that can provide guidance to employees or co-workers that are concerned about a colleague who is chemically dependent and stealing these medications. There are multiple supportive resources, including the Minnesota Nurse Peer Support Network and other resources that you can access in the links below. And I want to just conclude by saying that long-term care residents have a human right and federal right to have their pain medications protected. They have a right to receive their pain medications for pain relief as prescribed and ordered by their physician. I want to just point out that I included links to very helpful, thorough guidelines that care providers can adopt and adapt today, including the Mayo Clinic comprehensive intervention at the top of this slide. I also want to mention again the Minnesota Drug Diversion Prevention Pathway and the link to it, including if you're concerned about those thefts in hospitals in Minnesota and beyond. I also included links to excellent other articles that we identified in our literature review. And the one before the last one is the DEA Drugs of Abuse report that details the risks and the characteristics of each controlled substance in the United States. And the last resource there is about words we should avoid when we describe about people who are addicted to drugs, as we pointed out earlier. I want to just give a shout out to the new initiative that is called Elder Care IQ. And this platform allows the public, whether it's candidate residents and their family members and anybody else, to easily access the regulatory history, that is completed investigation reports, whether they're substantiated, unsubstantiated, or inconclusively determined at the care home level. This is a really critical advance in our ability to increase transparency of care providers in Minnesota, which is the basis for accountability. A big thank you to Scott Zerby and Kris, who are the brains and the people who executed the creation of this innovative platform that I hope other states and other countries will consider adopting. So I just want to close here again, and thank you for joining us today for this presentation. And I hope that it helps better understand this form of elder mistreatment and provide some insights and resources for addressing this phenomena in long-term care homes anywhere. Thank you so much.
Thank you for your interest in viewing this presentation. You can learn more about the work of elder voice advocates and our screening tool, Elder Care IQ, by going to their websites, whose addresses are provided at the end. I would also love to hear from you, and my email address is also provided. Thank you once again.